swallow. I'm not going to deal with this barium meal follows and barium enema because they will be too cumbersome for you to understand. But just remember all these things. Fallacies of the barium studies, false interpretations. What are the various fallacies of the barium studies? Why we are not doing all these type of things nowadays? There is a false interpretation of the results, right? The results are not very promising. Diagnostic yield is very low, right? Here we can only ascertain that it can be some growth, it can be some benign ulcer, it can be some malignant ulcer. There are certain things on the barium swallow by which we can say that the patient might be having some benign, patient might be having some malignant, but not with the certainty. No tissue sampling, right? It is only a diagnostic modality, no therapeutic intervention you can do. Interoperability, right? Interoperability is quite good as far as the barium studies are concerned. Like, to me it looks, I will say that it might be, it is a filling defect, it may be benign, it may be malignant. The second person will say, no, 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 it is likely malignant, you just do nothing. Third person can say, it looks benign to me, it may be some other some benign growth, some leiomyoma or something like that. So we are not able to ascertain. So the interobserver variability is there. Patient cooperation is must for the ingestion. Sometimes the patient are not able to ingest the barium, it is a very thick paste, right? So patient cooperation is must for the ingestion, and it is largely replaced by the endoscopy, right? In the era of endoscopy, when we were doing our post graduation and all these things, when the endoscopies were not there in the institute, when the endoscopy program were not so good in the institute, we usually rely on this barium swallow and barium enema. But with the advent of the good endoscopes, and now these studies are largely replaced by endoscopy. You will hardly find uh, the barium studies nowadays to be done in the institute as far as the gastroenterology practices are concerned. Regarding the city, utmost utility in gastroenterology, right? Various modalities used include you just remember the names, that is non-contrast city, contrast enhanced city. That if you give the contrast, then it is a contrast enhanced, right? The name itself is suggesting non-contrast, we are not giving any contrast, right? Because of the some comorbid conditions, like the patient is having the renal failure, something like that. Patient is having allergy to the contrast previously. CT enterography, just remember, CT enterography is for the delineation of the small intestine. CT enteroclysis is again a variant of the CT enterography. CT colography, again this colonic the by this CT scan we are going to assess the colon. And the triple phase CT, that TPCT, what we call, you will for the imaging of the liver space occupying liver gens, especially the patients who have got the hepatocellular carcinoma. We always go for this triple facility. The triple facility and its utility will be discussed by Dr. Tarana. And but just remember about these things. No one is going to ask you what how you are going to go on the non-contrast CT, contrast CT interrography. But just remember all these things. You are going to have all you are going to read about these things. They are going to be asked in your PG entrance exams and all these things. MRI of the abdomen, they are less used than the CT abdomen. Useful if CT is not helping out, especially if the patient has got some, you can say, especially the patient has got some liver, this intra-abdominal abscesses, cysts. In these type of things, there is a solid component is also, there is a liquid component is also in the cyst. So to exactly have the delineation, what is how much is the cystic component, how much is the solid component, how much is the fluid component of a particular mass, then the MRI of the abdomen is used. Otherwise, as far as the abdominal part is concerned, the CT usually tells us about the underlying disease. However, it needs expertise for interpretation result. There are very few persons who can exactly interpret the MRI of the abdomen, and it is one of the main, you can say, fallacies as far as our setup is concerned of this modality. Otherwise, it is it's sort of gold standard modality. The T1, T2, you must be knowing that T1 sequencing or T2 sequencings are the cine imaging. I will not discuss what is that. Help in differentiating the various interabdominal regions, especially the cystic masses, especially the malignant one, and malignant intestinal or peritoneal, or these type of uh, lesions. MRI of abdomen is of help. As far as the magnetic resonance cholangiopancreatography, and what we call the MRCP, it helps in, as the name itself is suggesting, there is something related to the this cholangiocytes, that is the biliary tract system and the pancreas. So it is helpful in imaging the hepatopancreaticobiliary tract system, right? Status of the IHBR death, that is the intrahepatic biliary radicals, right? CVD, common bile duct, PD, pancreatic duct, cystic duct is best assessed. Usually the city gives an idea, the very good idea rather, right? But if we are able to ascertain, if we are going to ascertain the biliary tract system, that if there is any you can say any pathology related to the biliary system, right, biliary radical system, then it is the gold standard. That is the, you directly go for the MRCP. Fallacies are there that no therapeutics can be done. It is only a diagnostic modality. As far as the upper GI endoscopy, it is my domain. So it is useful in evaluation of the esophagus, stomach, and the duodenum. Right. Upper GI endoscopy is only 100 centimeter tube. Fine. It cannot go. Can reach. This cannot reach. Sorry. It can't reach beyond DJ flexure. That is jejunal flexure. So evaluation of the jejunum is and ileum is not possible with the upper GI endoscopy. Gold standard for management of the upper GI bleeds. Upper GI bleeds, diagnostic, cancer diagnostics, right? Patient complaining of dysphagia, patient complaining of pain abdomen, patient complaining of the hematemesis, patient who are coming with this malabsorption type features and something like that. We usually take the patient who are having the celiac disease. We usually take the duodenal biopsies, right? So it is a gold standard, right? And the diagnostics biopsy samples from the accessible areas are taken uh, uh, from with the upper GI endoscope. So I urge you that if you happen to come to the C block, if you are free sometimes, once you will join the regular classes, then just come to the C block endoscopy room and just have a look at that, how we are going to perform the endoscopies and how we are going to diagnose the things which are pertaining to the esophageal, stomach, and the duodenal this duodenal lesions, right? But yes, it is a little bit I will not say fallacy, it is a limitation of the upper GI endoscopy that it cannot reach, it can't reach beyond DJ flexure. So evaluation of the jejunum and the ileum is not possible. Maximum to maximum we can reach up to the DJ flexure. Otherwise, most of the time we only are limited to the second part of the duodenum. We usually look till second part of the duodenum, and beyond that it becomes difficult. We have to negotiate markedly uh, to reach up to the D3 D4 part. Otherwise we are not able to do that. Maximum up to D2 part we can say. As for the lower G endoscopy, it includes the colonoscopy and sigmoidoscopy. Sigmoidoscopy, what we call the limited colonoscopy, because that we are going to see only till the sigmoid colon, right? It is a gold standard for the assessment of colon and the terminal ileum, right? Diagnostic biopsy, the colonoscopy, the full length colonoscopy is the gold standard for assessment of the colon and the terminal ileum. By retrograde route, we go through the colonoscope. It is even 50 or 160 centimeter tube, right? And retrogradely through the rectum, we negotiate this pipe through hole of the colon, reaches the cecum, and here the ileocecal valve is there. We negotiate the ileocecal valve through maneuvering, and you can say enter into the terminal ileum. But yes, again, the diagnostic biopsy samples can be taken from the accessible type. It cannot reach, can reach only, can't reach beyond terminal ileum, right? Only the only 10-20 centimeter of the ileum we are able to see. So whole of the, so elevation of the jejunum and the whole ileum is not possible, right? So despite the advent of this upper GI endoscopes, lower GI endoscopes, a large area of you can say the intestine, that is the jejunum, right, and a large part of the ileum. The duodenum we are able to see, right, by the upper GI endoscopes. The whole colonic assessment we are going to have by the colonoscopy, right? But a large area is left, that is the jejunum and the part of the ileum, excluding the terminal ileum. Here comes the role of the enteroscopy. Just remember this term. No one is going to ask you about what is a single balloon and double balloon enteroscopy, right? It is a balloon assisted devices. If 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 you are curious enough, if you have got then just go to the YouTube and just type this enteroscopy single double balloon. Then you will be able to see that how these processes are going to be performed. And so they are the balloon assisted devices for the assessment of the jejunum and the ileum. It is required the high expertise to perform, right? It is very they are very difficult because the intestine it used to slide away from the scope, right? Once you will see the video, then only you will be able to understand how they are going to perform. And verbally I cannot communicate about the procedure, right? It is a very time consuming procedure. Enteroscopy takes one and a half hour time, and it's a very time consuming, right? Ability to assess the whole of, but yes, it has got the ability to assess the whole of the small bowel by antegrade or the retrograde method, right? If you go by the mouth, if you go by the rectum, by this enteroscopes, then you are able to assess whole of the small bowel duodenum as well as the ileum. And it is useful in assessment of the obscure GI bleed. Obscure GI bleed that despite of all the you can modalities like the upper GI endoscopy, lower GI endoscopy, you are never able to ascertain. Patient is having the recurrent episodes of hematemesis, patient is having recurrent episodes of melena, patient is having the frequent HB fall, the FOBT is positive. FOBT, I will tell you what is FOBT. If the FOBT is positive, then it is useful in assessment of the obscure GI. Right now, we don't have this enteroscopy with us, but yes, upper GI endoscopy, lower GI endoscopy, we have a major chunk of the patient, and we are doing a lot in Delhi. So, dedicated enteroscopes for the whole small, for the small bowel assessment is not available with us. As far as the wireless capsule endoscopy, again, it is a diagnostic modality. It contains the name itself is the wireless capsule endoscopy. It is a wireless thing, something like that. It is containing some capsule type thing, and the endoscopy means the assessment of the you can see small bowel and large bowel by the camera. Right? So it is a device which contains a tiny camera, a recording chip, and light source is fixed in a transparent capsule. I will tell you. I will show you the clip. Right? Patient ingests the capsule. Camera takes recording for 8 to 12 hours, which are stored in an external transmitter. The data is the data is retrieved from the transmitter, right? And this capsule, it after taking the recordings, then it goes off. The battery dies out, but but the entire capsule comes out in the stools, right? It is a you can say it is a costly affair. The capsule per se costs around 35 to 40,000, and the whole procedure in a private setting may cost up to 60 to 70,000. In our setup also, that the capsule cost is there, so 25 to 30,000 is there, right? Here you can see that this is the capsule. Fine. This is the capsule which the patient is going to ingest, right? Here you can see there is a battery is there, right? Fine. Here is a lens, the camera is there, and there is a light source. Fine. These are the batteries, right? Lens, fine. The camera lens is there, and the light is there. So this capsule, the intact capsule, the patient is going to ingest, and after 8 to 12 hours, or as a bowel transit occurs, it is going to be eliminated in the stools after taking the recordings. Again, this is the external sensor. This is put on the skin here, on the abdomen, and these are the and this recording from this capsule, it is being recorded by this all these five or six sensors, right? Five or six sensors, and this is being recorded in this external transmitter, right? This is sort of hard disk, you can say. And this hard disk we put in our dedicated this software for this capsule endoscopy, and we are able to read the things. Again, I'm saying, if you're curious enough, if you got interest on in all these things, just go to the internet and take out the video, and you will be able to understand all these things. What is the capsule endoscopy? What is the enteroscopy, single and double balloon, right? Endoscope. Another modality is the endoscopic retrograde cholangiopancreatography, that is the ERCP. It is the congener, I will say the congener, but it is the therapeutic congener of the MRCP. It is a therapeutic modality for the CBD stone retrieval, pancreatic ductal stones, intrahepatic biliary ductal obstructions, intrahepatic biliary ductal obstruction, malignant obstruction of the biliary tract. Then through the ERCP, we are going to do the stenting and all these things to have the adequate biliary drainage. Fine. So again, this will be dealt with by the Dr. Rana. Uh, there are some other procedures as far as GI system is concerned. That is the secretory test. So I will just name about a few, and there is no need to go into the details of these things. That is a pentagastrin test. It is for the it is for the gastric acid output. That is a basal gastric output and an axial gastric output. Where the gastrin is being injected, and as a result of which we see the basal acid output and maximal acid output to have the assessment of the conditions of the stomach, right? We have the assessment of achlorohydria or the Jollinger-Ellison syndrome, which is a condition of the hyperchlorohydria, right? As far as the secretin CCK test is there, this is for the exocrine pancreatic function, whether the pancreas is functioning or not. We usually inject the secretin. What it causes, the secretin causes the you can say, enhancement of secretion by the exocrine part of the pancreas. And by this, we can see stool examination. In GI, if you are dealing with diarrheal diseases, if you are dealing with the malabsorption syndromes and all these things, is of utmost importance. You cannot deny the importance of the stool examination as far as the gastroenterology practices are concerned. Patient is coming to you for last 3 4 weeks history of the this diarrhea, having the 5 to 6 episodes of diarrhea and all these things. Then you just give them empirically antibiotic and all these things. Yes, you are right to an extent that you are giving the antibiotic just based on your experiences, based on your professional experiences, personal experience, that these type of organisms they usually cause the diarrhea and all these things. But yes, for the documentation, you have to go for the stool examination, at least 3 stool examination consecutively, to have the maximum yield, especially the parasitic infections like Entomibug, Giardia, which are very common in our setups, right? Especially if the summers are going on, right? And you will have a lot of patients near your household, even in your household, having the diarrheal episodes and all these things, and you just give them the fluoroquinolones and for all these fluoroquinolones, this metronidazole and all these things. That's okay, but for the diagnosis, we have to go with the stool examination. There is no shortcut to that. That you have to look for the over ancestor of the Entomoeba, Giardia, and the other parasitic organisms which can cause occult blood test, right? If the patient is having the occult blood test, as I told you, in the obscure GI bleed, the patient is having the marked anemia. Patient is having and if a patient is having marked anemia, there is no cause of the found. There is no cause found for the anemia, and but then what we do? Then we go usually by the this fecal occult blood test. That there is some lesion is there in the colon, in the intestine. By conventional method, we are not able to ascertain these things. And if the stool examination, there is a small amount of blood is lost, which is not being apparent, but yes, it will be reflected in stool by the Guic test or the immunohistochemistry test. Not going into details because they are beyond your scope. If the FOBT is positive, if the patient is having anemia or recurrent refractory anemia, right, then you will usually go by the FOBT, the 3 samples which you take for the FOBT assessment, and if they are there, then we have to move with the other investigation. So it can this tool examination can't be underemphasized in any circumstances as far as the gastroenterology practices are concerned. So with this, I finish today's class, and but yes, you should remember all these things. These are the things which are going to be asked in your practicals, in your viva, right? About the barium studies, about the endoscopies, right? About the this X-ray abdomen. Fine. In the surgery, we will always be given in the viva the X-ray of abdomen showing the intestinal obstruction or perforation or something like that. There is no escape from that, right? But and I have given the investigation from the basic to the exotic investigations, right? So that at least you should know about, or you should know that these are the procedures which are being done in the gastroenterology, right? The details of some of the procedures should be known to you. Otherwise, there is no need of going into detail of the wireless capsule endoscopy, CT enterography, and all these things. But yes, you should know these terms should not be foreign to you. If somebody asks you if somebody asks you, if you come across to see these type of procedures, right? If you come, so these things should not be foreign to you. That, oh, what is this? We have not read this. anyway. So it should not be like that. And with this, I conclude this class. And from next time onwards, we will start with the specific right from the mouth and so on. Right. Thank you. Thank you very much for the listening.